It is really my honor to introduce this video that we have made of essentially the HIV research at Ward 86. As you know, Ward 86 opened its doors in January 1983. We are celebrating our 40th anniversary of this clinic. And it isn't just the clinical care programs, but we have worked on a lot of research initiatives over the years to help shape HIV care across the nation and internationally. You will first hear from Dr. Anthony Fauci, who's the NIAID director, about the pivotal role that Ward 86 has served in performing HIV research. And then you'll hear in this video from key leaders, scientists, nurses, and patients at Ward 86 to really detail the history of research at Ward 86 and what we have contributed to the field. You'll hear from me again at the end of this video about some of our modern day research initiatives here at the clinic. Thank you so much.
Warm greetings to you all. This is Tony Fauci in Bethesda, Maryland. I'm delighted to join you today to say a few words at the CFAR Symposium and to congratulate Ward 86 on your upcoming 40th anniversary. I would like to thank my friend and colleague Monica Gandhi for this kind invitation. Ward 86 has a special place in AIDS history, dating back to the early dark days when San Francisco was the epicenter of the HIV epidemic in this country. Previously healthy young individuals were dying despite our best efforts to provide the supportive treatments available to us at that time. There were no established centers to provide the crucial care that was so urgently needed. And then, in January 1983, Ward 86 opened its doors, the first truly interdisciplinary AIDS-dedicated inpatient clinic to the world. The clinic launch was followed shortly by an opening of a designated inpatient ward for AIDS patients at San Francisco General Hospital called Ward 5A. What has become known as the San Francisco model became renowned as the best approach to HIV patient care in the world. Of course, and as will be celebrated today, the research over the years at Ward 86 has been stellar. From some of the earliest and most important clinical trials to implementation research, notably for people experiencing homelessness and other hard-to-reach individuals. Between the outpatient and the inpatient unit, Ward 86 has launched many research initiatives to improve the care of those living with HIV. I will mention just a few of these, all of which were critically important. Ward 86 investigators led some of the pivotal clinical trials of HIV medications, including the first AZT trial and important studies of combination antiretroviral therapy over the years. Ward 86 investigators have led the way in research on chronic inflammation and HIV infection. Ward 86 helped pioneer universal HIV therapy, regardless of CD4 count, implementing this strategy in 2010, 2 years before the national guidelines changed. Over the past decades, Ward 86 investigators have developed multiple innovative programs and disseminated their findings broadly as they became available to improve the care of people with HIV. Some of the efforts include the RAPID program to start HIV therapy as soon as possible after diagnosis, the Golden Compass program, a designated HIV and aging program for people over 50, the Pop-Up program to serve those with unstable housing and HIV, and most recently the SPLASH, or special programs for long-acting antiretrovirals to stop HIV, to use long-acting ART and PrEP in patients with challenges to adhering to oral ART. Time again, for 4 decades, Ward 86 has led the way with innovative cutting-edge research that has improved the lives of people living with HIV. I offer my heartfelt thanks for all your good work. Please keep well, Continue your outstanding work and enjoy the meeting.
We work in an academic setting, and one of the obvious features of academics is research. We take care of patients, we teach other people, but we try to understand what we're dealing with better. And with HIV, research has been just super important, and I think Ward 86 is a great example of that. Research allows us to describe a new disease like AIDS, understand the cause of the disease, understand better treatments for the complications, in this case of all the infections and cancers that we were seeing. But most importantly, perhaps, is treating the underlying cause. And while there have been very many important advances in research since improving the treatment of the virus, improving access to care, improving the outcome, improving the equity of care, I want to talk mostly about treating the virus. That's some of the things that I've been more involved in, especially in the early epidemic. It's important to realize that at first, when we started seeing patients in 1981, we knew nothing. We didn't know the disease, we didn't know the cause, we certainly didn't have any approaches to care or treatment. Ward 86 was a site for some of the early combinations, first with 2 drugs, later with 3 drugs. And I think our role in paving the way for the real breakthrough in 1996 with triple therapy was a really important one. But all that isn't to take away from the other really important work that was going on in Ward 86. People were interested in the prevention and treatment of the opportunistic infections. Donald Abrams with the use of aerosolized pentamidine to prevent PCP, the work that Bob Wachter and John Luce did, looking at high-dose steroids for the treatment of PCP, which showed that was an important component of helping reduce that bad outcome. And we began early on in what's been called now implementation research, really led in the very early days of the epidemic by Connie Wasey, Judith Cohen, and others, looking at AIDS in women and perinatal AIDS, the Perinatal AIDS Center, BAPAC, which also was heavily focused on Ward 86. So, and then since then, of course, Ward 86 has played a leading role in addressing health equity and improving the overall outcomes of this horrible epidemic. So a very important story, and I'm happy to have been part of that.
Well, when I think about the early days of Ward 86 and the introduction of a scientific agenda, I really do think back to 1982-83, when the decision to put a drop-in capability on Ward 86 evolved out of the research nurses and pharm docs who had garnished an area on the ward where the conference room is now, and where the pharmacist sits. And it was where we had our weekly conferences that convened the clinicians with everyone who was largely just looking for an antiretroviral that gave a negative viral culture, because that was all we had in those years to document that it had an effect on the virus. It really was the convening of that conference, that weekly conference, that put clinicians, nurses, and researchers in the same room to talk about the patients we'd seen that week, mostly a discussion of death and dying issues around the specifics. And it raised a lot of questions for the research aspects of it that eventually evolved into the AIDS Clinical Trials Group within IAID. And I would say, in my mind, was one of the critical ingredients in creating a conversation that cross-fertilized both the clinical challenges that were coming in daily and that we were seeing in that drop-in clinic, and the preparation that was being prepared to put that individual into a clinical trial type process and eventually evolved into clinical trials. And many of the researchers that did the research were also seeing patients themselves. And the kind of harmonization that occurred between clinicians, researchers, nurses, the need and infusion of nurse practitioners. Ward 86 was one of the first clinics to do that. I had been in Southeast Health Center where we, the year before, had decided to bring nurse practitioners into the clinic. And at the time, that was a huge discussion. Nobody thought it could work. But Ward 86 was critical in elevating nurse roles right from the very beginning, and it was largely manifested, visualized in that conference.
So I started my nursing career in 1982, having graduated from City College in the nursing program. And I got assigned to the medicine ward, 5C at San Francisco General. And that ward had perhaps more than half of its patients were people who were living and dying of AIDS. My original plan had been to be a midwife, but faced with what was happening with the beginnings of the AIDS pandemic, my career took a change. I think the role of research was so vital and continues to be vital, but back in the day in 1982, we had a name for the disease. By then it had been named AIDS, but the causative agent wasn't there, so the deep science that needed to take place was taking place at a furious pace. And little by little, understanding these horrible opportunistic infections and cancers that were killing so many people, the body of science grew, and that really helped our practice. It helped at times our despair. And we felt some sense of hope by contributing to this body of science. What struck me about Ward 86, in particular, the science coming out of there, was that at every moment we were trying to know what is it that we know about this disease, and how can we make sure that this standard of care that we're growing is going to be available to everybody. And so to me, was one of the guiding lights to this work, to this day. The last 10 years of my nursing career, I spent on Ward 86 working in expanded HIV testing in medical settings and linkage to care, and was so blessed to be part of the linkage to care team, the FAST team, and the RAPID team that really contributed to the research that showed how important it was to offer treatment as soon as people are given a diagnosis of HIV infection, and how it completely transformed how we did linkage to care and gave people hope on the very day when they felt hope was lost. It was a great honor being part of this multidisciplinary research that involved social work, navigators, nurses, nurse practitioners, doctors, researchers, in order to be able to continue to advance this, making sure that the highest standard of care was going to be available to everybody, regardless of their race, their ethnicity, their gender, where they came from, their immigration status, their housing status, etc.
I arrived at Ward 86 in 1983, and it was a time where we really didn't know much about the disease that we subsequently called AIDS. And so much of the early work that we did was in defining the manifestations of HIV infection, again, not even knowing that we were dealing with a virus at that time. My particular field of expertise was the AIDS-related complex, or things that weren't opportunistic infections or malignancies, but lymphadenopathy syndrome and ITP, immune thrombocytopenic purpura. In fact, I sent Dr. Gallo's lab samples from 36 patients with low platelet counts, and he use those to describe the AIDS virus. Subsequently, we did many studies with many agents, the Rock Hudson drug, HPA-23, and then we also looked at trying to prevent the opportunistic infections, and that was successful with inhaled pentamidine, a study that we did with physicians in the community. And in 1986, Diane Feinstein called Paul Volberding to a meeting and told him that he should meet with the providers in the community dealing with patients with this new disease. And Paul said after he went to the first meeting, hey, these are all your friends from the gay doctor group. Why don't you take this over? So I did, and we started to meet on a monthly basis, mainly for education, and I would tell them about clinical trials that we were doing at San Francisco General. And they said after a while, hey, Donald, why don't we do studies in our own practices and clinics? So that was the beginning of the County Community Consortium, the first practice-based research network in HIV medicine. It was launched in 1986. We did the aerosolized pentamidine. We subsequently did other prophylaxis studies for opportunistic infections. And then we became part of the clinical programs for clinical research in AIDS, the CPCRA from the NIAID. And that was very exciting, and we really had a network of nurses working in doctors' offices across the whole Bay Area. And that began my career in cannabis research, which actually then gave me a strong appreciation of the power of plants as medicine, which took me further into my subsequent career of integrative medicine. But it all began on Ward 86.
The HIV/AIDS Chest Clinic started in July 1995 with the goal of providing outpatient subspecialty pulmonary care for persons living with HIV in the same location that these individuals received their primary care on Ward 86. Throughout this time, our Ward 86 clinic patients and patients with HIV hospitalized at San Francisco General Hospital have graciously participated in clinical and translational research studies on HIV-associated lung diseases. These studies have focused on the most frequent pulmonary complications of AIDS and have changed over time, reflecting the changing epidemiology of AIDS in the United States. At first, clinical studies focused on improving the diagnosis of pneumocystis pneumonia, which was the leading AIDS-defining opportunistic infection in the US at the time, as well as a leading cause of morbidity and mortality. Studies from San Francisco General confirmed the utility of sputum induction and bronchoscopy with bronchoalveolar lavage alone for the diagnosis of PCP and led to the discontinuation of routine transbronchial biopsies for PCP diagnosis. San Francisco General was one of 8 clinical sites in the NIH-funded lung HIV study and one of 6 clinical sites in the NIH-funded lung HIV microbiome project, the first to study the lung microbiome in persons with and without HIV infection. As the epidemiology of AIDS has changed, so too have the HIV pulmonary research studies conducted at this institution. Over time, research studies transition from opportunistic pneumonias to chronic obstructive pulmonary disease, which is currently the most frequent pulmonary complication of AIDS in the US and an increasingly recognized complication for persons living with HIV worldwide.
I've been a client of Ward 86 since 1993, I believe it was. When I was first diagnosed, I knew nothing at all about HIV. I learned it by the seat of my pants. I didn't know who to ask and how to ask or what to do about it. So I figured that if you listen a little, you learn a lot. So I started listening, paying attention to what was going on around me, seeing how other people were reacting toward HIV and how should I be acting. I knew there was a lot of stigmatism. When the research trials came along, a lot of them were drug trials. I did not try those. I tried things such as aging and memory and the scope study so I could find out how long, what it was that I can do to help myself to improve. to get my health better. At the time, I think I must have been weighing 90 pounds. How can I get myself healthy enough so I can live? At the time, it was a death sentence. Paying attention to seeing people walking skeletons, seeing people with spots on their skin. How can I keep from getting there? In my circumstances, of course, at that time, it was a gay white man's disease. I fit none of those categories. So I didn't think I belonged anywhere. And when it came time to go into groups and such, there's really nothing out here for you, but you can sit in if you like. So when going to the scope study, I learned that my health will decline faster because I am HIV positive, because I have a lowered immune system. Talking to my doctors at that time, the only medication available was AZT. That was a nightmare. So the thing is, you have a choice, live with it or die with it. I chose to live. When the Golden Compass program came along, it was a chance for me to find out a lot of things that I knew not about myself. I could find out whether the aging medication, if I have to take medication for aging, if the aging medication would work with or with the HIV medication. How am I supposed to gather myself to do both at the same time? Because it seems like an impossible task. I wasn't supposed to live this long. When you're diagnosed, it's automatic death sentence. So what am I gonna do? Am I gonna sit back and watch other people improve? Will there be a cure before I'm gone?
So I just wanna tell the story of what happened in the 1990s in terms of research on Ward 86 and how that had an impact on the broader agenda. So I started on Ward 86 in July of 1993. This is when the Berlin Conference was happening. This was the International AIDS Society meeting in which the world found out that AZT was not only not helpful, it actually was causing harm. So it was, I think, one of the low points in the epidemic. And this is basically the work I started. And I say this because people need to realize that that was a time of when we really had no options and we didn't actually see what was going to happen in the next 3 years. We were all very desperate. And it was during that time that Paul Volberding, myself, and others at UCSF, we were approached by a group at the University of Pittsburgh with an idea that sounded completely crazy and still does, but at the time there was a potential for it working. This is basically the baboon bone marrow transplant many have heard about. I won't go into the preclinical work that went into this, but the idea was because baboons could not be infected with HIV, we may be able to train baboon cells to work in a person. Anyway, this quickly became a cause within the HIV community, within the activists, many of whom were really sort of frustrated with the pace of research and the lack of innovation. And so over the next couple of years, there was this national debate with mainly the community advocates who were very influential on one side, and the Institute of Medicine, the FDA, and all the stakeholders on the other, going back and forth of whether this should be done. And in December of 1995, everyone said, okay, I'm not sure if this is gonna work, probably won't, but maybe we'll learn something. And so we did it. We did a transplant with Jeff Getty, who was a very influential and inspiring AIDS activist, in early December 1995. And it was quite a scene, lots of drama, but it actually was successfully performed. And 10 days, 2 weeks later, to the shock of all of us, the patient actually got dramatically better, gained weight, all of his symptoms disappeared. He felt better than he had in years. I mean, his skin rash disappeared. He just all of a sudden looked healthy. So we had no idea what was going on. And it took us a few years to figure it out. But essentially what happened is that we'd given him a massive dose of radiation to prepare him for the transplant. And that reduced the amount of inflammation in his body, and that made him better. And from that observation, we began to realize that HIV is largely a disease of immunodeficiency and inflammation. And so we spent the next 25 years trying to figure out, why that might be and what to do about it. And of course, the UCSF SCOPE program and lots of careers, particularly Peter Hunt and everyone else, was sort of built on those early observations in which we realized that HIV was a disease of inflammation. And that to me illustrates the dynamic nature of what was happening on Ward 86 at that time, and still is happening, right? Where you had community in the clinic, patients in the clinic, the Department of Public Health, the university, industry, sponsors, donors, the whole global world sort of watching what was actually happening in our clinic, because we're always on the cutting edge, leading to sort of creative, innovative findings, how amazing Ward 86 was and still is. And we may take it for granted. I mean, I will say that I traveled the world a fair amount back in the day talking about what we were doing, and everywhere I went, people wanted to sort of figure out what was the magic sauce that made everything so unique at Ward 86. And I always thought it was this amazing collaboration between patients and providers and the academic community and all the virologists and immunology at UCSF and all the resources that were available. And of course, the Department of Public Health, everyone. We're really focused and all came together on Ward 86 at that time and since then. So lots of lessons learned, always inspiring place to work. One of my favorite places in the world.
That was an amazing look at the rich history of HIV research at Ward 86 since the inception of the clinic in January 1983. And I wanted to tell you a little bit more about our present day research. I became medical director of Ward 86 in January of 2014, and we have launched several programs since then, but importantly, published on those programs to disseminate this research. In 2013, we started the RAPID program. This is a program to start people living with HIV on same-day therapy, or as close to the day of diagnosis as possible, to help get them on therapy right away. We have published and disseminated findings on that program. In January of 2017, we launched the Golden Compass program. This is a program, you heard from Hulda Brown earlier today, which really looks at the care of those aging with HIV. We have in the Golden Compass program 4 components of the program. We work on the heart and mind. We work on frailty and bone health. We work on social aspects of living with HIV when you're older, and we work on navigating you to essential services like dental, hearing, and vision. We have published multiple papers on the Golden Compass program to disseminate those findings. In January of 2019, we launched the Pop-Up program. This is an important program for those who are homeless or marginally housed living with HIV. And this is a very important program where we provide very low barrier access to care. You can come in any time and you're surrounded by a group of people, a team who helps you navigate your HIV and primary care. We have published papers on the Pop-Up program to disseminate that model of care. And then finally, this year, we launched SPLASH. SPLASH stands for Special Programs for Long-Acting Antiretroviral Therapy to Stop HIV. And this is really harnessing novel technology of long-acting treatments, long-acting pre-exposure prophylaxis, or PrEP, for those who are adherence challenged at Ward 86 and across the city. And it's exciting to use these new technologies in such an important patient population. So we really hope that you enjoyed this video about the history of research at Ward 86. Thank you so much for being here. Oh, you look nice.
So when did it stop?
It stopped when you had just mentioned Peter's work and all the inflammation work, and then you were just about to say, this is my favorite place in the world, and then that's really where it ends.
All right. Yeah, I mean, why I think that story was important was, first of all, it showed how desperate things were back in the time, but it also showed how incredibly powerful the community was, because the community really wanted this. No one else did, right? The Institute of Medicine had a 3-day meeting, the FDA had a 2-day meeting. I mean, there was 2 years of a massive amount of debate about this. And for the most part, people didn't think we were ready to do this, but the community demanded it. And so it happened. It was just reflected the challenging times. And it's quite different, but the community was extremely powerful and very influential, and they remain so to today. And what happened then, I think, in the 90s, is that in San Francisco we built the secret sauce. Did I use that word?
You did, but they didn't get to it.
All right, secret sauce that makes this place tick, in my opinion, right, is that we have this academic center that's well resourced, with lots of world experts. We have a highly engaged community that is very influential and at the table. We have an incredibly supportive Department of Public Health, and we're surrounded by a lot of industry partners. And we have Ward 86, right, in the middle, which is just an amazing, just go up to 86, you always feel this energy and all these patients, and they reflect the entire diversity of the epidemic. And so you sort of put all that stuff together, and then you essentially build the cohorts to sort of capture all this. And then from that, we've had innovation after innovation after innovation. But it's because I don't think anywhere in the world you have such a strong interaction between the community and the Department of Public Health and academics and industry partners and so forth than what we see on Ward 86.
Okay, so I'm going to go quickly because we really want to get to Cura and pop-up. So I sort of mentioned this in terms of our clinical programs, but you could actually take each clinical program and say that we have always tried to put out research about them. So universal ART in 2010, 2 years before anyone did universal ART in this country. Dr. Fauci mentioned that. Our PrEP program in 2013, the Salute Clinic, and then Golden Compass in 2017. Hulda did the splits here during that launch, if anyone was here in 2017. 2019 was our pop-up launch, and then Splash we launched last year. And so if you think about the rapid research, it was very important. This is a paper that was led by Susa Coffey, and really a lot of work by the teams in this room to extract all of this information from the medical record of how people in the rapid program did. And you can see in this red box that our initial patients in rapid, as they continue to have other concomitant health challenges like substance use and mental health disorders and homelessness. Just that sounds familiar. But really, despite that all, the rapid program here, the time to virologic suppression essentially was as good as anywhere or better with starting medications as close to the time of diagnosis as possible. And really, even a year out, there was a 91.2% virologic suppression rate in this patient population. And that made a lot of waves. And then the Golden Compass program, when we started that in 2017, now we're up to 73% of patients in this city being over 50. So even more relevant, really these 4 components of it. This was launched by fundamentally, a lot of the pathophysiology of aging was worked on by Steve and Peter and their groups. And you can see that this kind of Part 9 program at the top, the northern point, the eastern point being geriatrics care, the southern point being more social components, and then kind of basic navigation to essential services in the western point. And there has been a lot of, this is such a great picture of Val Robb when the Chronicle covered this new program, but we have put out papers about the geriatric conditions and healthcare utilization in Golden Compass. How did we do 2 years after our launch? A pharmacy-led program. Janet and her team is extremely active in reducing polypharmacy in these patients. And then I won't talk about research at pop-up because Matt will cover that. But Kat Christopoulos did really important work that essentially everyone keeps on saying 10% of people living with HIV carry 90% of the virus. Where did that come from? That really came from Kat's work on Ward 86 to say that it is this patient population that's not suppressed, that is still driving forward the pandemic, not only not good for their individual morbidity and mortality, but forward transmission. And so if you take that 10% that's still holding 90% of the virus, and we all know the concomitant challenges, what do you do with that patient population to help innovate, to think about how to get them suppressed? And that really was this long-acting program and the demonstration project that we started to say, we're desperate, let's take these long-acting medications and see if that helps. So Liz did not mention that our rates of virologic suppression in the pop-up are much better than the city virologic suppression rate in those who are homeless, which is 27%. Liz said that we're up to 67%. That's remarkably higher, but it doesn't mean that we still can't try to get those remaining patients suppressed. And so this was, I remember when we first did this, we got quite a bit of, the following phrases were used: Wild West, crazy, really going out there because we were trying to use these in patient populations that were not studied. They are studied with virologic suppression and registrational clinical trials, and we use these medications in patients who aren't always virologically suppressed. And we hired Francis, who is incredible, to help us. And we're meeting today at noon, today's flash meeting at noon. And we go over each patient. And yes, the first 100 patients look good, meaning 41 of those first 100 patients are not virologically suppressed, 59 are virologically suppressed. And all of those patients who aren't virologically suppressed, almost all of them suppressed. Now we're going to add to this data. I think you all know that there's been 2 failures in about maybe 130 patients. Jan leaned over to me and said 2 over 130, and that was exactly 1.4%, which is the rate of virologic failure in the clinical trials. So if we're at the same as in the clinical trials, when we're studying it in such a complicated patient population, that's amazing. Thanks to people like Maddie, who's going out and like helping give injections to people. So I think we're doing well. And then really, I did some really amazing qualitative work where people say, this totally makes sense to me. Why wouldn't I be offered this therapy? Even when I'm viremic, this has really changed my life. And I think you're going to hear that on January 25th. We're going to have some patients share their experience. So do look at her qualitative data. And then I'm going to say that Jan designed a new splash logo, and I don't like it because there's like some red in there and that looks like you hit the vein. But then again, no, some people don't like the top one, so we're going to have a vote probably on the logo. But thank you to the splash team. And then the final thing I'll say is, this is that bread and butter. We need to improve our care, and that is really the Revival of Care program that we launched in April 2022. Really, that you can see these 2 other pillars: mental health care and substance use care. So many people in the audience are helping with that. This was Ward 86 in 1985, standing in front of the steps. This is Ward 86 now, and thank you so much for everything. Let's go to Steve, who's going to talk about care. You only have 8 minutes.
All right. So point of my previous thing in the video was that we have this capacity here in Ward 86 to innovate. And what I want to say is that it didn't stop in the 90s. It's going on to this day. And the work that we're doing is largely built on the SCOPE program, which is now basically more or less run by Michael Peluso, who's been quite busy with lots of projects over the past couple of years. Becky and this entire extended team of investigators. Unfortunately, I don't have any time to go into much detail, but we have the administrative staff, we have the clinicians, we have the DEM, we have the core immunology lab, we have the AIDS specimen bank, and it's all tied together by the patients on Ward 86. And based on that platform, we are now supporting locally dozens of studies. Internationally, I don't know, maybe up to 100 studies over any 2 to 3 year period. Basically bring in people from 86 for the most part, get blood, get biologic specimens, distribute them throughout the San Francisco area and essentially throughout the globe with lots of people doing cure-related research. Don't have time to go into these various different individual stories, and perhaps another time. Another critical, so let me just go into 4 or 5 different innovative things that are happening. One is Sugi. Sugi Lee is actually running this incredibly intensive biologic study of what happens when antiretroviral therapy is started on basically the first week or the second week or the third week or the fourth week, and has built up this, I think, the premier cohort now in the world of the treatment of hyperacute HIV infection. And she's now beginning to use this to support studies again across the country. And that's Sugi's leading that. You probably have heard about this study, the so-called kitchen sink study, the JAW studies. This is basically, I think, the first clinical trial that actually has been implemented with a specific design to actually achieve a long-term remission. The study is incredibly intensive.
Michael's been running the clinical part, Rachel's been running the laboratory part. It's essentially finishing up right now. We should be getting data out to everybody shortly on what happened. But we did this in the context of COVID. We enrolled 10 people in this very intensive study, 500 visits and 10 people. You can imagine it's a unique study and highly innovative. Priscilla Shu is doing this amazing study, first in human, and one of the first in HIV and one of the first in human in terms of all diseases, in which she's basically taking a virus, sticking it into a molecular scissors, CRISPR-Cas9, that essentially is designed to go around the body, find the HIV provirus and cut it. And when you cut the HIV provirus in the cell, that provirus becomes dead. And in theory, if we can make this work, and this is what Mike McCune, our good friend Mike McCune, has been doing. He is, through the Gates Foundation, has a 10-20 year plan to sort of come up with an idea in which we're going to be able to go out anywhere, go out San Francisco to an encampment, find someone with HIV and say, listen, you have HIV, and we can take care of it with one shot in the arm. All right. Now that is aspirational, but it's possible, and it's starting here in this first in people study that Priscilla's doing, in which we're actually going to be giving people this approach with this sort of enzyme that we actually think is going to be able to go throughout the body, find HIV and kill it. That's probably overpromising a bit, but Mike has a plan, and if Mike has a plan, he usually figures out how to do it. It's not going to happen anytime short, but you know, we're going to be highly engaged in trying to make this happen. We're also doing other really innovative gene therapy studies that are ongoing. One involves taking cells out of the body, cutting out CCR5, putting it back in. This group at UCSF, believe it or not, did the first randomized study of CAR T cells ever done anywhere. CAR T cells are these cells that are designed to actually kill specific cells. It vaguely worked back in the 1990s, and then it went on to cancer for the last 20 years, and now people are being cured all over the place with CAR T cells. Now that whole CAR T cell world is coming back to HIV, and we're again now resuming our CAR T cell work to see if we can cure HIV. We're doing very intensive studies of treatment interruption to sort of figure out exactly what's happening when the virus begins to rebound. No one's ever done that before. Lily Cohn is sort of leading this, again with Rachel and others. Tim Hendricks is doing this amazing work with his team, where basically we're taking people with HIV and we're actually sending them to UC Davis, where they have this incredible super MRI type machine that's actually supposed to be the best in the world. And we're now able to visualize in people using labeled antibodies and this machine where the virus is throughout the body. And again, another example of something that we're doing that's basically being done for the first time anywhere. So back to you, Monica.
And then we're going to end with pop-up, and maybe we'll have a few questions that I'll be quick. Okay, excellent. Thank you so much for that. Thanks.
Great. Thanks so much, everyone. Really nice to be here as part of this month-long celebration of our 40th anniversary. So I'm going to talk about pop-up research. Liz Imbert, my close colleague, talked a little bit about pop-up earlier. But I'm going to highlight some of the research studies that have been important for our program. So two really important studies I want to mention early on that showed the importance of a low barrier option for people experiencing homelessness. These were led by Asa Clemenzi-Ellen, who I think many of us know. On the left side, Asa showed a dose-dependent relationship with housing instability and lower viral suppression, higher viral load. And on the right side, we also see that housing instability has a dose-dependent relationship with more acute care utilization and lower primary care engagement. It's really showing people are going in for acute care ER visits and whatnot, but not primary care and not attaining viral suppression. It's really important to just mention, housing is essential for addressing any of these needs. And what we're doing in pop-up and our motivations have really been, what do we do for people in the meantime? What do we do now for these needs and to address these disparities? So I'm going to talk about a couple of studies that were really key in informing the pop-up model. The first one I want to mention, this was first authored by Maddie Conte, he's a medical student been working with us for the past couple of years. And really our motivation was to understand, what do patients want? we may have our own ideas, but we started with a discrete choice experiment to understand patient preferences for what a care model might look like that would better meet their needs. We enrolled patients at Ward 86 who were experiencing homelessness, not suppressed, struggling to engage in care. And in this study, among 65 people that we enrolled, about half who were street homeless and half who were using stimulants, we found that the far and away number one priority was a provider who knew them as a person. So, people wanted drop-in access, they wanted low barrier access, but they wanted to see somebody that knew them, that had a relationship with them, not just somebody that might be new to them each time. So that was a really important early insight. We found that people were willing to trade a fair bit of financial incentives to have that, up to $30 per visit, to have somebody that knew them, had a relationship with them. The drop-in access was also important, as were incentives, but that was a key initial insight. We delved into this further during another study that Liz led during the COVID pandemic. So this was in 2020, really trying to hone in on A, are there more flexible options that we should be offering to people? And B, what does this relationship really mean? So we did this discrete choice experiment, including in-person visits, or do people want the flexibility of a telehealth visit? Do they want a navigator to help get them to clinic or help them get to a phone visit if need be? Do they want to go to another site in the Tenderloin in addition to Ward 86 and have that flexibility? And then for this relationship, we wanted to know, do people want to see the same person every time? Or are they open to seeing a small group of people that all know them and work together for their care? So we found something that was really interesting. So 1/3 of patients that we enrolled really wanted to see the same provider no matter what. This is this group in red over here. And they were willing to trade many other features in order to have that sort of relationship with a single person. The other 2/3 of people really wanted flexibility. So they didn't care so much about seeing the same person every time, but they wanted to drop in, they wanted to be able to go to another site, they wanted a navigator. And so that flexibility was important. So this also gave us some important insights into how we wanted to innovate our model. Importantly, no one wanted telehealth. Everyone wanted to come in person. That was a key priority, as we've seen with other things in Ward 86. So Liz mentioned a little bit the pop-up elements earlier. I just want to highlight how these studies inform. So drop-in access is a key component of our model. Relationship-centered care, we really conceptualize this as a small team of providers, social workers, nursing, where people can work with all of us, but we can also cohort. For those people that want to see the same person, they know if they come on a Thursday, they're going to see Liz. They know that they can work with particular social workers, for example. Comprehensive primary care services is really facilitated by a weekly case conference where a psychiatrist comes, gives us really expert consultative advice on how to manage complex mental health issues. One of our providers is an addiction medicine specialist. And so this ability to really coordinate providing same day on the spot addiction medicine, primary care, and psychiatric care is really important. So just talk about a few outcomes for our program. So this is a study where we took the first 112 patients that enrolled and followed them over 12 months to understand care engagement and viral suppression. So in this cohort, half of people were street homeless when they first enrolled with us. 100% had a substance use disorder, most with methamphetamines, and 70% had a diagnosed mental health issue. So we saw really high rates of engagement. Over this first 12 months, 70% of people had at least one visit in each 4-month period when we divided this up into 4-month periods over the year. But over half of people had at least a 90-day gap in care at one point in time. So we saw people consistently, but there were gaps in a population that we really would hope to see regularly. These are all people that are not suppressed when they're coming in and have a number of reasons why we want to see them regularly in clinic. Looking at viral suppression, as Liz mentioned, about 2/3 of patients got virally suppressed at any point over the course of this year. But when we look at a snapshot at the end of that 12-month period, only 44% remained virally suppressed. A quarter were not suppressed. And importantly, a quarter hadn't been in the clinic in a while, and so we didn't have any data on them. I'll highlight also 9% of patients died, mostly due to drug overdoses, just highlighting the high mortality in our population. So this care engagement and sort of need to continue to improve viral suppression is motivating now 2 important directions that I want to talk about in pop-up. So the first is more innovation on mobile care. So this is, we're doing a study of this now led by Maddie Conte, and Rodrigo Aguilar, one of our social workers, is going out for these mobile visits. This is ongoing. We're really excited about it. We're essentially going to find people that we haven't seen in a bit. Either they're not suppressed and we haven't seen them in a month, or we haven't seen them in longer. And this is a social work driven visit where we're really trying to build on that relationship, address psychosocial needs, address housing needs, income needs, to try to get people back in, talking to people about long acting as well. So Maddie's collected data on this. We're looking at return to care after these visits. We're looking at viral suppression. We're also doing qualitative interviews to understand the patient experience with these visits and sort of what the mechanism of action might be. So very exciting new direction. And then the last thing I'll say is a really exciting new direction that we have is an EHE R01 that's being led by Dr. Kat Christopoulos as the PI, where we're working with Ward 86 as well as Needle Exchange in San Francisco, 2 FQHCs in the East Bay, to really adapt the pop-up model, add in mobile care, and then figure out sort of what, how is this going to look and what are the key implementation components at these very different sites across the Bay Area. Another key component of the study is going to be working with sites in the community, emergency departments, psychiatric emergency services, jails, to understand sort of how can we lower the barrier for entry into this type of low barrier care for people that are maybe not coming into clinic at all, but are touching the system in other places. So this is a really exciting study that we'll be working on. We just started this year. We're working on our formative interviews and some of the initial implementation mapping with the community sites. So more to come on that as well. So I'll wrap up there, and we're a little bit over time. I just want to finish with a quote from one of our patients in a recent qualitative interview on mobile care. In describing his team at Ward 86, he said, "It's like a group of friends that are helping you survive." And I just thought that was really emblematic of this community, our family here, and what makes it such a special place to work at Ward 86. So I want to thank all of you. I want to thank Liz Imbert for all of her leadership, Pop-Up as the clinical lead, Monica Gandhi and Diane Jones for their leadership and guiding us in developing this research program. All of you on the Pop-Up team and all of you for listening. So thanks so much.